This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, everybody, and thank you for joining us for our HealthyU webinar series. Today's topic is sleep medicine. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of the screen. We'll answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. Today's presenter is Dr. Ali. Dr. Ali grew up in Northern Virginia, where he received his Bachelor of Science from Cornell University. Following his undergraduate degree, Dr. Ali attended Virginia Commonwealth University School of Medicine. He then completed his residency at Rutgers University, New Jersey Medical School in internal medicine and fellowship training in pulmonary and critical care at VCU School of Medicine. Dr. Ali finished his professional training at Yale University, where he completed his sleep medicine fellowship. Dr. Ali, the floor is yours. Let me just get your PowerPoint up. All right, it's all you.
All right. Thank you, Jonathan. Hi, how are you? Good afternoon. So today we'll talk about sleep medicine. Sleep is one of those things we don't really, think about a whole lot. But if you think about how much time we spend sleeping, it's a big component of our lives. And what we're really in sleep, realizing more and more that sleep is really a big component of not just how we feel the next day. It's also, our heart health, our lungs health, our health for our overall body. Really, a lot of it depends on good quality sleep. So what we're going to talk about today, and again, during the whole talk, just ask me any question. If you have any question, just raise your hand and we'll take a break and then we'll talk about it. So a little bit of topics for the day. So we'll talk about the history of sleep medicine and different stages of sleep that we go through throughout the night. Then we'll talk about different sleep disorders that we see. And then a big component of that is sleep apnea. So we'll spend a little bit of time talking about sleep apnea and all the things that can happen if that goes untreated. All right, next slide, please. All right, so history of sleep medicine. So the first, if you go back to literature, the first time anyone really talked about sleep medicine was back in 1834. Dr. Robert McNeish, he's a Scottish surgeon who talked about in the philosophy of sleep. He talked about it's really one of the first books on sleep medicine. Defines sleep as an intermediate state between wakefulness and death. Next slide, please. A couple of years after, in 1836, Charles Dickens described a character in his novel, The Pickwick Papers, a character named Young Dropsy, we described him as a wonderful fat boy who's constantly hungry, red in the face, and is always falling asleep in the middle of tasks. So that was sort of like the early documentation of some of the extreme sleep apnea patients that we see today, who are always sleepy during the day, always, even after getting 7-8 hours of sleep the night before, falling asleep throughout the day. Yeah, next slide. And then fast forward to 1928, Hans Berger is a German psychiatrist who came up with EEG, and that really gave us the first opportunity for the first time to study sleep medicine, because then we were able to put patients on EEG and see the different wave pattern that happens during sleep, and really we were able to tell the difference between what happens when you were sleeping versus what happens when you're awake. All right, next slide. So really quick, so between 1930s and 40s, so we were able to recognize for the first time the different patterns of sleep that we have. And in 1950s, that was the time when we learned about sleep, REM sleep, which is the dream sleep, which is the stage 4 of the sleep. Next slide. This is Dr. Dement. This is one of the psychiatrists from Stanford who really described the difference between REM and non-REM sleep. That was back in 1960. And he's really the father of sleep medicine and established American Academy of Sleep Medicine that still exists today. That was back in 1975. Next slide. And fast forward to 1981, Dr. Sullivan is an Australian physician who first came up with CPAP. So if you think about CPAP, which we talk about, hear about all the time, it's not that old. It's only been around since 1983 when it was approved for sleep apnea. It's only been around since the 80s. So he actually used the reverse. He used the reverse of he reversed the vacuum cleaner to use CPAP to treat sleep apnea. Up until then, the only treatment that we had for obstructive sleep apnea was tracheostomy. Okay, next slide. All right, so let's talk about sleep a little bit. So sleep is a rapidly reversible state of reduced responsiveness, motor function, and metabolism. Even till this day, we still don't really know the purpose of sleep. But if you think about how much time we spend sleeping, it's about 1/3 of our time. And all the complaints that we have, about 60% of the complaints that we have in primary care setting is sleep-related problems. So a lot of insomnia, not getting good quality sleep, and also not just initiating sleep, trouble maintaining sleep. Next slide. So about 25% of the symptoms are related to untreated sleep apnea. Again, insomnia is very common, 30 to 50%. And then we see a lot of restless leg. And then a lot of times there's a sort of like a coexisting of, there's a lot of symptoms that kind of coexist at the same time. All right, next slide. So let's talk about the different stages of sleep. So if you think about sleep, so really the two main categories, the REM sleep and a non-REM sleep. So REM sleep is the time when we dream, right? And then non-REM is pretty much everything in between. If you think about the whole sleep cycle, each cycle lasts about an hour and a half to about 2 hours or so. And if you're getting 8 hours of sleep, you're going through the cycle. Each cycle is about an hour and a half to 2 hours, about 4 or 5 times a night. When we score sleep study, what we do is we kind of break all those hours in the 30 seconds epoch, and then we score each epoch. All right, next slide. So so the first stage is, and I have a picture of the first stage. If you click on the next slide, there you go. So the first one is a wake stage. This is when we're finally, as you're laying in bed, as you're kind of getting drowsy, that's really when we have you're still awake, but you're not really completely awake yet. You're kind of in between. That's still a awake phase. And then we have the first stage, the stage 1, when we kind of slowly transition into a kind of drowsy sleep. Next slide. And then we go into stage 2, which is, again, it's still, you're a little bit more, the sleep is a little bit more deep, a little deeper, but it's still pretty shallow sleep. Again, the stage 1 and stage 2, probably about 50% of the sleep is combination of this two. Next slide. And again, there's different ways to kind of recognize this different pattern, which I'm not going to get into right now. Next slide. All right, then you have going to stage 3 sleep. This is the deep sleep, or we also call it a slow wave sleep. This is when our sleep waves kind of slow down a little bit. This is when you really get into stage 3 sleep. That's when it gets really tough to wake up from, because that's really when you're getting a much deeper sleep. And that's about 10 to 20% of the time. It happens more during the first half. As the night kind of goes on, you get less and less of the deep sleep. So some of the things that we see, especially for younger patients, a lot of sleepwalking, sleep talking, night terrors, all those things happen most of the time during the stage 3 sleep. Next slide. All right, so this is kind of the night terror that I was talking about. Then you have finally named the stage 4 sleep, which is the REM sleep. That's really when our whole body kind of goes numb, and we're really using your diaphragm to breathe because the whole body is atonic. And the reason that is from an evolutionary standpoint, if you think about, because this is the stage of the sleep when you're dreaming. So from evolutionary standpoint, our whole body is inhibited from acting out our dreams. That way, we don't cause injury to ourselves or our partners. Right. Next slide. So this just kind of talks about the different characteristics of REM sleep. Again, this is about 18 to 20% of the sleep. All right, next slide. So this is kind of when we talked about like the dreaming that happens, and a lot of the sleep disorders that we heard about, sleep apnea, REM behavior disorder, all happen during REM sleep. Next slide. So this is sort of like a hypnogram. So what it shows is the different stages of sleep as the night goes on. So if you look at this patient, so this patient's been sleeping from 8 p.m. till about 7 a.m. So during that 8-hour window, the patient went through the cycle about 1 to 5 times. So as you see, as the night went on, he or she had gotten more and more of the REM sleep, which is kind of why, if you think about all the, and I'm sure you've kind of heard of it before, like, we see a lot of stroke, a lot of heart attack happens in the early morning hours, because that's really the time when we have more and more REM sleep. REM sleep, even though it's a pretty, that's when our whole body is numb, hemodynamically, it's actually a pretty active sleep. There's a lot going on in our body during the REM sleep. So a lot of the time, that fluctuation of blood pressure, our oxygen level, our carbon dioxide level, that fluctuation can cause heart attack, stroke. So it's really important, the disease that can happen during REM sleep, like sleep apnea, to treat all these conditions, because those diseases are more relevant, more significant during a REM sleep. And if you look at how refreshing we feel the next day, you really got to have more and more of stage 3 and 4. So stage 2 is the deep sleep that we talked about before, and the stage 4 is the REM sleep that we talked about. So you really need a lot of stage 3 and 4 to feel refreshed in the morning. So what we see, a lot of the patients with sleep apnea or sleep-related disorders, even if you get like 7 to 8 hours of sleep, if you don't have a lot of stage 3 and 4 sleep, you wouldn't feel refreshed in the morning. What happens, especially with sleep apnea patients, because they stop breathing during sleep, anytime you stop breathing, your sleep cycle kind of throws you back to your shallow sleep. So even if you get 7 to 8 hours of sleep, you're gonna have a lot of stage 1 and 2 sleep, which is, again, it's still sleep, but it's just not gonna give you the refreshing feeling in the morning. So what a lot of sleep apnea patients, they would have, they would wake up feeling drowsy even after getting a good night's sleep. All right, next slide. All right, so we kind of talked about different sleep stages. Again, so the deeper the sleep, the more the arousal threshold. So for stage 1 and 2, it's really easy to wake up from. Stage 3 and 4 is a lot harder to wake up from, just because they're a lot deeper sleep. All right, next cycle. Alrighty, and the next slide. Alrighty, so now we're going to talk about different sleep disorders. So the first part is going to be the sleep-related breathing disorders. So this is your sleep apnea. It's the most common one that we see in the community. And then some of the other things that we talked about, restless leg, insomnia, again, it's very common. Narcolepsy is, we hear about that a lot. We don't see, it's not that common. It's less than 1% of the patient population. And parasomnia is essentially all the things that other children have, sleep talking, sleep walking. A lot of the time, this patient's going to grow out of it. But sleep talking as an adult, again, it's very common and it's pretty much benign. And then we have circadian rhythm disorders. These are the shift workers, and especially in our healthcare, we have a lot of people who are working night shift. There's nurses, physicians, so they would have trouble. And again, if this goes on for a long time, they can have trouble kind of adjusting to the change of biological clock. Because if we're spending the night waking up, spending the time awake, it's difficult to fall asleep during the day. Then we have a lot of young adults, kids in their high school years. We see a lot of delayed sleep phase syndrome where they have trouble falling asleep until late in the morning, so 1 or 2 in the morning. And for elderly folks, we see a lot of early stage advanced sleep, excuse me, advanced sleep phase where they're falling asleep by 8 or 9 o'clock. Next slide. Okay, so we'll talk about insomnia and insufficient sleep a little bit, which is, again, it's very common in our society with such a demand for a job, family, friends. Sleep is one of those things that always kind of falls behind because we're not getting enough sleep. And unfortunately, we see this a lot now. We have a lot of patients who would come in and say, I do fine with 4 or 5 hours of sleep, which could be true. Excuse me, I have a little cold. Again, if you look at the spectrum, so majority of the patient population would need about 7 to 8 hours of sleep a day in order to function well, in order to feel good the next day, in order to feel refreshed. But there is going to be a spectrum of population who are going to be fine with 4 or 5 hours of sleep. Then there's going to be another spectrum who would need 8, 10, 12 hours of sleep to feel good the next day. But if you look at the data, there's more and more data coming out that 7 to 8 hours of sleep is really the number that you need, not just to feel good the next day. There's a lot of healing that takes place during sleep. So if you end up with less sleep, and if that builds up over time, the chronic sleep deprivation can increase the risk of dementia, Alzheimer, heart disease, diabetes, weight gain, all those things. So there is a kind of like a long-term damage that could happen if there is chronic buildup of sleep deprivation. If you look at our society now, 30% of adults in the US report less than 6 hours of sleep. And again, the lifestyle in the US is really, it's part of the reason why we have such a almost like an epidemic sleep deprivation. There is as I was saying before, there's a lot of shift workers in the US. So circadian rhythm disorders is very common. These are the patients who are who are up all night working, and they would sleep during the day. The problem with that is, even if you make up your sleep during the day, it's almost impossible to make up for 8 hours of sleep during the day. So what happens with those patients over time, they end up with chronic sleep deprivation because you're probably getting about 5, 6 hours of sleep during the day, which is just not enough. And again, there's a lot of patients with chronic pain who would have pain throughout the night, and that would wake them up from sleep. There's a lot of anxiety, depression, especially depression is common. We see a lot of early morning awakening with depression. There's a lot of medication that can cause insomnia. And again, like I was saying before, and again, for some patients, it's just normal to sleep 4 or 5 hours a night, which is a normal variant. Again, it's okay for them, but long term, it can cause damage down the road. Next slide. So for the management, one of the things that we talk about for insomnia management, again, this is one of the most common problem that we have in sleep clinic and even primary care clinic. It's insomnia. How do we manage insomnia? And one of the things that we talk about, which is kind of counterintuitive, is sleep restriction, which is essentially you want to limit the hours, the time you spend in bed trying to sleep. So the bed really should be for sleep and intimacy. That's the only purpose of bed. So you don't want to lay down just to unwind from the day. So if your if your goal is to get, let's say, 5 or 6 hours of sleep, you don't want to spend more than 5 or 6 hours in bed. So watching TV, which is very common in bed, it's a big no-no, because that's if you spend all this time unwinding, watching TV, scrolling through your phone, all those things, then the brain kind of gets confused to say, hey, am I supposed to unwind? Am I supposed to kind of socialize, or am I supposed to fall asleep? So really use the bed to sleep. So go to bed when you're ready to fall asleep, not just when you're tired. Again, nap. There's nothing wrong with nap, but anytime someone is napping consistently, that's just an indication that they're not getting enough sleep the night before. So if you can avoid nap, that's a good thing, because that just builds more of a sleep drive. So when you're in bed at night, you'd be a lot quicker, it'd be easier to fall asleep because you have more of a sleep drive. Exercise, it's a daily exercise, is actually really good for insomnia. And one of the treatments that we have for chronic insomnia patients is exercise. It's one of those things that kind of helps you to get, in a way, almost like you're tired from the day, and one of the things that kind of helps you fall asleep quicker is daily exercise. And caffeine. This one of those things kind of gets overlooked. So if you think of caffeine, so the active ingredient of caffeine, it's just like any other medicine, stays in our system for a long time. So for most patients with normal kidney and normal liver function, caffeine will stay in our system for about 6 to 10 hours. So if you think about drinking coffee, if you're drinking coffee at 4 p.m., it's going to stay in your system. Half of that caffeine is going to stay in your system by 10 o'clock. So if your goal is to go to bed by 10, you might want to you really want to limit your caffeine intake at least about 12 hours before. So, I would say for most patients, would recommend that, and maybe after 10 o'clock, definitely not after lunch. You don't want to take caffeine because it's going to stay in the system a long time, and it's going to make it difficult to not just to fall asleep, it will be difficult to maintain sleep. And the same goes for decaffeinated coffee too, because if you look at decaf coffee, will have about 10, 20 milligram caffeine in it, which can really affect the quality of your sleep and the sleep environment. So, there's specific things you can do, and everyone's a little different, but yeah, you want to have a dark environment. Any kind of light will affect the melatonin level. So melatonin gets it gets blocked by melatonin, which helps us fall asleep. It gets blocked by light. So any kind of exposure to light will affect your melatonin level, and it's going to make it difficult to fall asleep. So as the night goes on, let's say from the evening on, you want to lower your exposure to light. Same thing with the noise, temperature. Again, the optimum temperature for sleep, it's about 68, 69. Which again, it might be a little cold for someone, but that's really you want to avoid hot temperature, because it makes it difficult to fall asleep. And alcohol. So alcohol is kind of tricky. Unfortunately, we see a lot of use of alcohol for to fall asleep, because it does reduce the time it takes to fall asleep. But what happens with alcohol is that as it gets broken down with into its different metabolites, as the night goes on, those metabolites will wake you up throughout the night. So you end up with a horrible quality of sleep with alcohol. So again, if you have to drink, it's recommended that you drink at least several hours, 3-4 hours before you fall asleep. That way, those metabolites have already been appropriately absorbed, and it's not going to break down. It's not going to fragment your sleep. All right, next slide. All right, so let's talk about sleep apnea. So again, I want to start off with primary snoring. This is, if you think of a snoring, which is extremely common. So our airway, if you look at our normal anatomy, so our airway starts from our nose, our mouth, and goes to our lungs. So any obstruction along the way, from the nose, from the mouth, the windpipe to our lungs, will cause turbulence, and that's what causes the snoring noise. Again, it doesn't necessarily, if you snore, it doesn't mean that you have sleep apnea, but that means there's some kind of obstruction along the way, and that obstruction can cause fragmentation of sleep. It can cause low oxygen level. Yeah, next slide. Alrighty. So the first stage of that is upper airway resistance syndrome, where you don't really have sleep apnea, but you have some component of sleep apnea. You have some snoring, some obstruction along the way. It's not really waking you up from sleep all the way, but it's causing some sort of fragmentation. And then a little bit more advanced stage of that is obstructive sleep apnea, which I always say that we hear about all the time. And then they have central sleep apnea, which is not that common. Central sleep apnea is it's more common in patients with history of stroke in the past, or any history of severe heart failure. Next slide. And then complex sleep apnea is a combination of both obstructive and central. Next slide. All right, so this is just a diagram of what happens during obstructive sleep apnea. So if you look at the top diagram, so you have the two air pointing down. So the air going through your nose, the air going through your mouth, all the air is going to end up in the same common pathway, and that's going to go down the lung. So right here, and what happens with sleep apnea is, if you look at the tongue, we only see the top portion of the tongue, but behind the tongue, there's a lot of tissue that just there. So as we gain weight, there's more fat around our belly. But if you look at all there's a lot more tissue, soft tissue that happens in that kind of exists in our mouth area, and behind the tongue and behind the nose, that area kind of gets narrow and narrow. So this is more common for patients with a thicker neck, shorter neck. You just don't have enough empty space. So what happens during sleep, especially during the REM sleep, what we talked about, where whole body goes numb, we kind of lose all our muscle tone, and all the soft tissue gets pulled by the gravity, and it blocks the airway. So if you look at the bottom diagram, so you see the squiggly line, that's when the air kind of gets blocked. Some air is still kind of getting through, but if you look at the bottom right corner, that airway is completely blocked, and that will cause the apnea component of sleep apnea. This is when we hear people saying, oh, there are times when I feel like my spouse is not breathing, or there's a pause in between breaths. So that's what's going on. They're trying to take a breath, but the airway gets blocked because of the tongue and all those things, kind of all the soft tissue that kind of falls on the airway. Next slide. So this is just another diagram of what happens during sleep apnea. So if you look at the space behind the mouth and the airway, so the two red arrow, if you look at the first one is the retropalatal space. So that's the space between our esophagus, our food pipe, and our tongue, and then really the back of our mouth. And then the next arrow is the retrolingual space. That's space between our esophagus and the tongue. Again, if you look at that space, that's a really narrow space. So it doesn't really take that much soft tissue to block that area. So when we're making that noise, like, when we're snoring, we're trying to open up the area. Our body's trying to open up the area, but if it doesn't, that's when we start breathing And that's really what happens repeatedly during when with someone with the sleep apnea. Next slide. So this just tells you, this kind of shows the diagram. This is kind of what we see when we do a sleep study in a lab. What we see is that, again, someone is breathing, and again, there's a stoppage, there's an apnea of the breath, and that shows on a sleep study, and that just tells us that you stop breathing, and it tells us how often that happens. It tells us how low your oxygen level goes and for how long. And next slide. Again, this is just another diagram of what happens. Again, this patient was breathing really fast, and then there's a stoppage of airflow, and then your breathing goes, your oxygen level goes down, and then the body kind of catches up, breathes fast again to get the oxygen level up and to get the carbon dioxide level low, and it happens again. So this pattern kind of repeats itself throughout the night. All right, next slide. Again, it's the same, some of the things that we already talked about. Next slide. Again, similar thing. This is a sleep study with the apnea where they completely stop breathing and they start again. And then if you see after they stop breathing, the oxygen level dips down and it picks up again when they start breathing again. Next slide. Again, it's very common, right? It says 15 to 30% in male, 10 to 15% in the female. Again, a majority of this patient population is still, unfortunately, still undiagnosed, and it's more common in African American. Next slide. Risk factors, like we talked about. So age is a big factor because, as for a healthy young patient, it's a lot easier to cope with the symptoms. They have a lot of healthy lung. So even if you stop breathing for a long period of time, because a healthy lung would have a lot of reserve oxygen, the oxygen level is not gonna go down that much. But as we get older, our reserve is not as good as before, let's say. So you're a lot more prone to desaturation. Again, it's more common in male than female. Again, so body habit is definitely relevant. So the bigger the patient, the higher the BMI, the more at risk. Again, the neck size, the waist to hip ratio, all those things were relevant. Again, it's common in about 11% of, so not all of them are obese, but because in a lot of it is upper airway anatomy. So for someone who is non-obese, if they have a smaller mouth, larger tongue, they would have the risk factors for having sleep apnea. So about 11% in men with normal weight would have sleep apnea, about 21% in men who are overweight, and 63% who are obese. Next slide. So this kind of tells you, so this gives you a diagram of what happens to the upper airway anatomy. So this is more common for patients who are not obese, but they have sleep apnea. A lot of it depends on their anatomy. So if you look at the bottom, the top left, this patient, you can see the entire uvula. You can see some of the soft, the soft pillar, the tonsillar pillar, the soft tissue. Again, the airway is much bigger than if you compare that to the diagram in B. Again, you can see partially, you can see the uvula, and then if you go down to bottom left, you barely see the uvula, and then bottom right, you don't see the uvula at all. So so A is the airway that doesn't really have that much risk factor because you have a lot more empty space for air to go through, as opposed to for diagram in D, there's not a whole lot of space. So that patient is not at risk for having sleep apnea, especially when they go to sleep. When your entire body goes atonic, it loses all your muscle tone, and gravity pulls everything down and blocks your airway. So if we add that plus the body habitus, so then you have shorter neck, a lot more fatty tissue around the airway. All those things will add up to the risk factors, and these are the patients we see with severe sleep apnea. Right, next slide. Again, some of the other anatomy that can increase your risk of sleep apnea. Again, someone with a high arch, smaller upper jaw would have a higher risk. Next slide. scalloping of the tongue, again, it's very common. So essentially, it's if the tongue size is proportionally bigger than the size of your mouth, the edge of the tongue is going to hit all the teeth around it, that can cause indentation. So it's just called scalloping of the tongue, which looks like a scallop. But yeah, so that's also not a risk factor for sleep apnea. Okay, next slide. Again, these are more relevant for kids. So, and someone with big tonsils. Again, if you look at the picture on the right, there's not a. So this patient has a grade 4 tonsils, large uvula, and they're at extremely high risk for sleep apnea. So again, this is more common in children. So the management for children with sleep apnea is a little different because with special children less than 10 years old, non-obese, if you take out their tonsils, if you take out their adenoid gland and tonsils, they're healed and they don't have sleep apnea anymore. Unfortunately, for adults, it's not the same. There's no, so back in the days, up till until about 20 years ago, they used to, even for adults, they used to take out the tonsil, they would take out the adenoid gland, they would take out the uvula, thinking that would treat sleep apnea. But what we realized for adults is that we have obstruction at multiple levels, so that's not the standard of care anymore. So for adults, even if you have large tonsils, the guideline is not to take them out, because what happens down the road, even if you take them out, they would still have sleep apnea. But for kids, once you take them out, they're pretty much cured. All right, next slide. This is septum deviation. Again, it's very common, especially for a lot of mouth breathing patients. So patients who breathe with their mouth open, we see a lot of septal deviation where the septum of the nose is a little deviated, causing obstruction and makes them harder to breathe through their nose. So the brain will realize over time that you're not getting enough air, and you would open your mouth. These are the patients who wake up with their dry mouth because their mouth was open the whole night during sleep. Next slide. Again, these are patients with a small jaw or jaw that's pushed back. They're at higher risk for sleep apnea. Next slide. We already talked about some of these risk factors: alcohol, benzodiazepines, Valium, Xanax, Ativan. All those things will increase the risk for sleep apnea. Next slide. Okay. Yeah, some of the things, so we already talked about most of this. So some of the things that the symptoms that most commonly they come with, again, you're gonna have non-refreshing sleep. So you would have 7 to 8, you'd get 7 to 8 hours sleep at night, but you would wake up feeling tired and fatigued. So that's very common. Poor concentration, just not feeling refreshed when you wake up in the morning. A lot of snoring. A lot of the patient would have restless. They would be restless the whole time. They'd be very active sleepers. So there's a lot of flailing of the legs, the arms during sleep, and and witness apnea. That's when you see your spouse not breathing, which is again very common in sleep apnea patients. Next slide. I'm just going to go through this on this slide quick. So the way we diagnose, we'd have them come in. We have that patient come into our sleep lab, or for now, actually, what we're doing more and more, if they're pretty healthy, otherwise they don't have any underlying risk, underlying stroke or heart failure, we're doing a sleep study at home, which really essentially tells us how often we stop breathing to the point that your oxygen level is going low or is causing a lot of fragmentation of sleep. And if that happens more than 5 times an hour, that's by definition sleep apnea. Next slide. So this is an example of a home study. So this is you would have a nasal cannula that goes under your nose, and you have a belt that goes under that you put around your chest, which measures chest rise, and you have a pulse ox on your finger. So this will tell us, again, this is not for everyone, but for someone who is healthy otherwise, we can do this study at home, and this will tell us how often this patient stops breathing and how low their oxygen gets, and that will give us the diagnosis. Next slide. So this is kind of how the data looks when we get the report. Next slide. And like we were saying before, so if someone stops breathing about 5 to 15 times an hour, that's mild. If someone stops breathing between 60 to 30, that's moderate. If it happens more than 30 times an hour, that's severe sleep apnea. Next slide. So we can talk, we can kind of skip through some of this slide. So it essentially talks about how sleep apnea, untreated sleep apnea, can cause heart hypertension. Next slide. Different arrhythmias, so atrial fibrillation, atrial flutter, heart failure, even stroke. Actually, if you look at, there's a, yeah, this been kind of, we've known about this for about 10 years now. Untreated sleep apnea could be a risk factor for stroke by itself, just like hypertension. Sleep apnea itself can increase the risk of stroke down in future. Next slide. This we just talked about. Next slide. I'm going to talk about treatment a little bit. Yeah, so the treatment, again, so first you want to have some sleep hygiene that we already talked about, creating a safe environment for sleep, low temperature, no light, no noise, and then avoid alcohol, avoid benzodiazepines, so Xanax, Ativan, all those things long-term, not a good medication, not a good strategy for sleep. And the next slide. And weight loss, definitely. And then for moderate to severe sleep apnea, so CPAP is really the key treatment. So essentially what it does, when you put on that mask, whether it's a nasal mask or a full face mask, it's just pushing room air. So you're not getting oxygen, you're just getting room air. It creates a cushion of air, and it pushes all the soft tissue that we saw, the uvula, the tongue, all those things. It kind of pushes everything out of the way and keeps your airway open. With someone with sleep apnea, once you start wearing CPAP, you're not going to have obstruction of your breathing anymore. So there shouldn't be any more snoring. Because of that, there's no more fragmentation of sleep. So, and you're going to be able to sleep through the night. Because what we see with sleep apnea patients, they're waking up throughout the night. And most of the time, you don't even realize you're waking up. These are microarousal, and that's what causes the non-refreshing sleep in the morning. So the point of this CPAP is to keep your airway open the whole time, so there is no more fragmentation of sleep. So when you wake up in the morning, you would have more of the stage 3 and 4 sleep that we just talked about. Next slide. Yeah, and this just kind of talks about how efficient CPAP can be over time. Next slide. There are other treatments for sleep apnea. So again, for someone with a really mild sleep apnea, we can talk about the oral appliance. Well, what it is kind of like a retainer that you put on before you go to sleep. And what it pushes your lower jaw forward, opens in the back of your throat. So again, for someone who is non-obese, someone who is healthy otherwise, has good dental hygiene, it's a pretty good, effective treatment, especially for someone who doesn't want to use CPAP to treat their sleep apnea. Next slide. This is an example of an oral piece. Again, this has a little hinge in between the top and the bottom layer, and it pushes your lower jaw forward, opens up the back of your throat, so the air has a pathway to go to our lungs. Again, for someone with a mild sleep apnea, this is a pretty effective treatment modality. Next slide. Yeah, and then in the extreme case, we talked about tonsillectomy and adenoidectomy. Again, really these are for kids, not for adults anymore. And back in the day, they used to do uvuloparangioplasty, which is what they take out the uvula, the part of your back part of your tongue, some of the soft tissue, but it's not the guideline anymore. So they stopped doing this. And then trach is like the most extreme treatment that we have now for ICU patients, but that's uncommon. That's for someone who haven't been able to find any other treatment modality. Next slide. I think we're pretty, so this is kind of how the surgery goes. Again, it's not the treatment modality anymore, so we don't do this anymore. Next slide. I think that's it. Sorry, I had to rush through some of the slides at the end.
Yeah, no problem at all. So if anybody has any questions, you can put them at the Q&A feature at the bottom of the screen. All questions are anonymous to protect your privacy. Dr. Ali, are you able to see the Q&A feature at the bottom?
Yeah.
Okay. If
All
you'd like,
right. So the first one, I'm going to start from, I'm going to start with the first one. People with autoimmune disease are often subject to fatigue during the daytime. So autoimmune disease, that's a good question. So we see fibromyalgia is one of those things that I can think of. Patients with fibromyalgia, a lot of them have poor sleep, and there is specific sleep pattern that we see with those patients. So it's always a possibility that those patients have underlying sleep disorders. So it's always a good idea to get a sleep study to make sure we're not missing anything. Again, the link how that happens is we don't really know for sure, but some of this autoimmune disease, we see a lot of sleep disorders are common among this patient population. What about the effect of sugar? Does sugar impact quality of sleep the way caffeine does? So sugar, that's an interesting question. That's actually, I've never thought of that before, but I've definitely seen that with my kids. So I have a couple of toddlers, but yeah, they're definitely a lot more awake if they have sugar, after dinner. Not that we know of, at least I can't think of any literature saying that sugar will keep us up, just like caffeine does. But I can imagine like sugar will probably make you a little hyperactive. So maybe right before going to sleep, sugar probably not a good idea, but I'm gonna have to look that up, but that's a good question. I listen to podcasts to fall asleep. Is it likely to impact the quality of my sleep? That's good. So listening is not, I don't think so. So the whole point of what we want to do while you're trying to fall asleep, you don't want to do anything active. So watching TV or getting doing something that will kind of stimulate your brain it's counterproductive, right? So reading a book, something that's a little bit more boring, it's always a good idea. So from that standpoint, listening to podcasts might be okay. Again, it's part of it, and a lot of people do that as part of their meditation. It should be okay as long as it's not too loud. It should be okay. And you also want to find a way to turn it off so it's not running all throughout the night. If you can find a way to kind of turn it off as you fall asleep, then yeah, it shouldn't really affect the quality of sleep. But what I was saying before, let's say, because again, we hear this a lot. They would say, oh, I go to bed around 10 o'clock, but I don't fall asleep until 11. So what do you do during that hour, right? So so one way to think about that is, if you know that it's taking you an hour to fall asleep every day, don't even go to bed an hour before. Go to bed when you want to go to bed when you're ready to fall asleep. You don't want to go to bed when you're just tired. Bed is really for sleep, right? So if you can hold off going to bed until you're ready to fall asleep, that's really the most effective way, the sleep hygiene technique that we have, that we know of. It's not the medication. All the medication that we have for insomnia, unfortunately, the way they work, they kind of wipe us out. They kind of mask the symptom. They're not really taking care of the underlying sleep problem. And a lot of the time you wake up kind of feeling groggy, and same thing with we see a lot more with the benzodiazepines, so more common with Ativan or Xanax or Valium. Even for melatonin, we see a lot of grogginess when they wake up in the morning. So again, every once in a while, once a month, a couple of times a month, that's okay. We don't want to make that a pattern. I wake up 2 to 3 times each night to urinate. How does that impact the overall quality of sleep? That's a good question. So nocturnal urination, so believe it or not, waking up at night to go to the bathroom, that happens more in sleep apnea patients. So what happens is when we have untreated sleep apnea, and this goes on for a long time, our oxygen level goes down, right? That stresses the lungs. That stress the stresses the right side of our heart, and then our heart tells our kidneys to make more urine. So the patients with sleep apnea and who are not being treated, they make more urine at night, and they go to the bed. They go to the bathroom a lot at night. A lot of the time, as we get older, for a female, we would say, oh, it's just menopausal symptoms. For a male, we see, oh, it's probably the prostate, which could be true, but a lot of this nocturnal urination that we're seeing probably from untreated sleep apnea. So it's always a good idea, if you're waking up 2 to 3 times a night, each night, to urinate, might not be a bad idea to get a sleep study to make sure you don't have underlying sleep apnea. Let's see. Have you had any success with non-invasive modalities like breathing exercise, yoga therapy, physical therapy, acupuncture? Yeah, that's a good question. So acupuncture, I don't know. Physical therapy or breathing exercise, all those things are really good for insomnia. So like I was saying before, meditation. There is actually, for talking about breathing exercise, if someone is a mouth breather, there are exercises out there that you can do. Actually, I'm sure if you YouTube it, you'll be able to find it. There are exercises out there that teaches you how to use your nose for breathing. Because what happens, again, if you look at from evolutionary standpoint, our nose is designed for breathing. So there's a lot of filtration that takes place inside our nose that doesn't happen if you're mouth breathing. The reason you're mouth breathing is because, again, if someone has congestion or a lot of septal deviation, their brain is telling them, hey, you're not getting enough air through your nose, so you got to open your mouth. But all this filtration is not going to happen through your mouth. So there are breathing exercises that you can do that kind of teaches it teaches you how to breathe through your nose. And sometimes they're effective, sometimes they're not. But yoga therapy, yeah, that could be good for insomnia, but not as much for sleep apnea. The other thing that we see with sleep apnea is positional therapy. Again, someone with mild sleep apnea, if they have a lot of, if you think of all the snoring, stop breathing, all those things happen a lot more if you're sleeping on your back. So once you put them on their side, those events kind of go down a little bit. So positional therapy is it's also it's very effective for a lot of patients where they don't snore as much, or they don't have as much a stoppage of breathing when they sleep on their side or on their stomach. So how much does sleep apnea affect dementia? That's a good, interesting question. So we don't really know how much, but what we see is that chronic sleep deprivation, like I was saying before, there is some, not causational, but more of like a association data showing that you're at high risk of dementia for down the road if you have chronic sleep deprivation. If you think about dementia in general and sleep apnea, so dementia itself can cause a lot of non-refreshing sleep. So those patients with Alzheimer, Parkinson's, dementia, we see is that there's not a lot of refreshing sleep. If you have sleep apnea, the sleep quality suffers even more. So definitely for those patients, it's really important to at least treat whatever we can treat. So in dementia is almost, sometimes there's not a whole lot of treatment out there, but if there's any component of their sleep that we can fix, which is sleep apnea is one of them, we should definitely try to diagnose them and fix it by putting them on treatment if possible. Can you recommend any sleep prescription medication to help insomnia? Are any over-the-counter drugs useful? So that's a very common question. Unfortunately, no. During my fellowship at Yale, we had 12 sleep specialists. None of them prescribed any sleep medications. And that's because there's no medication out there that works, consistently. Again, if someone has um, structural abnormalities. So they have dementia, they have some other stroke or some other structural problem with their brain, and they just can't go to sleep without it. That's a different story. But for most patients who are just busy with their daily lives, should be able to sleep. It's really the only medication, the only treatment that really works is CBTI, which is a cognitive behavioral therapy for insomnia. That's essentially the talk therapy. That's really what works consistently from a double-blinded, placebo-controlled, randomized controlled trial that shows that's the only treatment that works consistently. In terms of medication that are out there, so, Zantac, Zartec, antihistamine, melatonin, again, they work, but they work in a way that they kind of wipe you out. You wake up feeling groggy. So again, every once in a while, it's okay, but definitely it's not something you want to do on routinely. And one quick thing about melatonin, the melatonin, if you look at the prescription, they did a study where they looked at how much each milligram of melatonin each brand has. Because it's over the counter, it's not strictly regulated. So they found out that each 1 milligram melatonin, depending on the brand, could have anywhere between 1 to 20 milligram melatonin. So the point is, if you use melatonin, again, American Sleep Academy doesn't recommend it. If you do want to use it, you want to use it from the same brand and not more than 3 milligram at night. So that's really the upper limit. Maybe 5 if you really want it, but definitely not more than 5 milligram a night. What else? Inspire. Yeah, so Inspire is it's a pacemaker for someone with a moderate to severe sleep apnea. So essentially, it's just like a regular pacemaker. It goes under the right collarbone. It's a pretty pretty aggressive way of treating it. Again, someone has severe sleep apnea. They've tried everything else. Nothing else works. So for those patients, it's another modality that we can use. What it does is so they make one incision under the chin, under the collar, in the neck, and then the pacemaker goes under the clavicle, under your tissue, and has a wire that goes to your neck, goes to your tongue, and kind of gives you a shock. And so each breath, your tongue gets a little shock, and the tongue pushes forward, and that opens the back of your throat. Again, it's a treatment modality that's out there and it works, but it's relatively new. It got approved by FDA back in 2014. So some of the long-term data is still coming out, which we don't. But so far, it looks promising, but it's a little bit more invasive compared to, let's say, CPAP or oral appliance. How do you make an appointment for a sleep study? So in order to make a sleep study, so we have at Mather, we have a sleep center, which has been there for about 20 plus years. So yeah, all you got to do is make a call, and we'll go from there. And then I'm sure Jonathan will have all our information. Jonathan, do you have information about our sleep lab?
Yes, I can send everything to all the attendees on how they can make an appointment.
Right, good. And what time should melatonin be taken? So melatonin, you want to take at least about half an hour before your desired onset of sleep. So if you want to fall asleep at 10 o'clock, I would say you want to take melatonin about between 9 and 9:30. But yeah, you don't want to take more than 3 milligrams. So even 1 milligram melatonin is like 100 times more than how much our body makes. So really, you want to start off with low dose. So start off with 1 milligram, about half an hour to an hour before you want to fall asleep, and you can slowly increase the dose, but not more than 3 to 4 milligram a night. There's a lot of messaging about us keeping the cell phone out of the bedroom. So cell phone use in bed, yeah, that's tough. Do it, those things. It's been so are there studies that shows the electromagnetic frequency produced by cell can affect the sleep? Not that I know, but I'm gonna have to look into it. Yeah, that I'm not sure. But what dim the light, exposure to light will lower your melatonin level and it will make it harder to fall asleep, number one. And also cell phone is very stimulating. So you don't want to use anything stimulating as you're trying to fall asleep. So those are the two main big things that we hear about insomnia and cell phone use in bed. But in terms of the effect of electromagnetic frequency, that I have to look that up after having a stroke. Why I might need more sleep each night after having a stroke. So it's not that you need more sleep after having a stroke, but what we're seeing is that with stroke patients, they're at higher risk for having sleep apnea, more both obstructive and central sleep apnea. So those patients, so anytime someone has a history of stroke, they should all routinely have a sleep study to make sure they don't have underlying sleep apnea as well, because not only untreated sleep apnea is a risk factor for stroke, a lot of the stroke patients after having stroke can develop central or obstructive sleep apnea. To what degree sleep medicine is individualized? So that's a good question. Sleep medicine, in general, as medicine is being as there's more and more advancement of sleep medicine, medicine in general, sleep medicine is also becoming more and more individualized. If you think about one common example would be a CPAP. If you think about a CPAP, I mean, CPAP, the mask used to be a big mask, that kind of one mask for everyone. But now there are 20, 30 different masks out there, and there's a lot of different variation of the mask. So CPAP is not as uncomfortable as it used to be, because we have a lot more individualized, customized masks that are out there that works for different shapes and different anatomy, because they all work. You just gotta find the right mask that fits for your anatomy. Same thing with oral appliance. Oral appliance is heavily individualized, right? I mean, the way we make the oral appliance, you go to a dentist, get the mold, and then based on your anatomy, they will design the oral appliance that works for your anatomy. So in the sleep routine, it's again, it's another individual thing that you kind of have to find out what works for you, what works for your to kind of get that comfortable zone before you fall asleep. If a woman in her 40s has difficulty maintaining sleep, waking up 8 times a night, night terrors, doesn't have a sleep apnea, what are the treatment options? If so, what? So women in her 40s having difficulty maintaining sleep, waking up several times a night. So, experiencing night terrors, sleep paralysis. So, one of the things we can talk about, if you're having that much difficulty with sleep, and we only ruled out sleep apnea, one of the things we can talk about is, could there be some underlying narcolepsy? So a lot of those patients who have non-refreshing sleep, but they don't have sleep apnea, but they're sleepy throughout the day, we have another sleep study that we do. So sleep study at night, and then the next day we do a multiple sleep latency test. So what we do is you spend the night in a sleep lab, we rule out sleep apnea, and the next day you take naps every 2 hours, and we see how quickly you fall asleep after getting a good night's sleep the night before, or how quickly you go into REM sleep. So that tells us if there is any other underlying sleep disorders that can cause the daytime sleepiness. So these are narcolepsy patients or patients with idiopathic hypersomnia. And the other thing that's common for a lot of the patients, female patients really, if you think about the classic symptoms of sleep apnea, the witness apnea, snoring, gasping, choking, these are more common in elderly male population. For female, what we're seeing is a lot more insomnia, a lot more behavioral symptoms, a lot of anxiety, depression. So especially female in their menopausal, perimenopausal, postmenopausal time, we see a lot of anxiety, depression that can by itself cause non-refreshing sleep throughout the night. And then you wake up feeling tired the next day. I think that's all the questions that I have.
Yeah, all right, awesome. So thank you, Dr. Ali, and thanks for everyone joining today. If you have any additional questions, please email them to matherhospital@northwell.edu. Once you exit the webinar, you will see a link to complete a brief survey. If you could please complete the survey, your feedback is extremely important to us to help us plan future programs. Thank you all again for joining today. If you'd like to view past webinars, you can see them at www.matherhospital.org/HealthyU. Thank you guys again and have a great day.
Right. Thank you, guys.